Hi and greetings from Chicago. This is ASCO 2019. I have the pleasure of chairing the leukemia and stem cell transplant session this afternoon, actually coming up shortly. And I thought I would talk for a few minutes about what's happening in AML and some of the other topics that actually get coverage in my session. So broadly speaking, in AML, there's a lot going on. The United States has seen 8 new approvals in the last 2 years. There's certainly a lot of activity in newly diagnosed AML, in relapsed AML, and also in the incorporation of novel targeted agents based on next-generation sequencing and profiling of patients, which has really changed the way that we think about treating all of AML, younger patients and older patients. So on the randomized trial front, we are eagerly awaiting the results of venetoclax added to azacitidine versus azacitidine alone. That trial is awaited, not presented here at ASCO, but the combination of venetoclax with hypomethylating agents has certainly resulted in some impressive complete response numbers, and we're hoping for an overall survival benefit as well. Global international trials are recruiting patients also for prasinostat, which is a histone deacetylase inhibitor, an HDAC inhibitor, in combination with azacitidine versus azacitidine. And we also are looking for randomized trial results, not quite imminently, but coming down the pike for uproleselan, which is an E-selectin antagonist combined with chemotherapy. So it's nice to have randomized phase 3 trials pending in AML, and these are anticipated to be practice-changing. Moving to the meeting at hand, we have news about ivosidenib, which has recently attained FDA approval for newly diagnosed AML. It had been previously approved for relapsed refractory disease, and at this meeting, I am actually presenting a poster on updated results from ivosidenib in the treatment of newly diagnosed patients. These are 34 patients who hadn't been treated previously for AML. Difficult to treat patients, older patients, primarily ones who might not have done well with intensive types of therapy, and with durable responses. So the CR plus CRh rate of over 40%, very manageable toxicities, certainly prolonged survival for those who are responding. And I think it's really, it's out there in the United States as an approved therapy, and it's a really big question now of who are the patients who should be selected for upfront treatment with ivosidenib, in addition to those who are treated in relapse. If I didn't say it before, for those of you who may not be up to date on these things, ivosidenib is an IDH1 inhibitor. Also, we are presenting data from my group at Cornell on CPX351, which is a liposomal construct, but really more than just a liposome. It's a 5-to-1 molar ratio of 7 and 3 of cytarabine and daunorubicin, but this drug has actually beaten 7 and 3 in a randomized trial of patients with secondary AML, a particularly difficult subtype of AML to treat, including patients with myelodysplasia-related changes and therapy-related AML. What we're trying to do, and the poster from my group is preliminary work, we have more coming, but these are patients who had been treated with lower intensity regimens for AML, and maybe those regimens didn't work. So what we find a lot is that for patients between 60 and 75, one's really having a hard time choosing what to give those patients. Do you give an intensive regimen like 7 plus 3 plus gemtuzumab, for example, or for the secondary patients, do you give them CPX351, which shows a survival benefit, or what about venetoclax and azacitidine for those who are less fit? Very complicated decision making currently. And what we felt was that there might be a lot of patients older than 60 who might be tried on a hypomethylating based regimen, but perhaps it didn't work or didn't put the patient into complete remission. So we have an investigator initiated trial of CPX351 for patients who have been treated for AML, but with some sort of a lower intensity regimen, generally hypomethylating agent based, that didn't work. and then they go on to receive CPX. So in our trial so far, we were reporting just preliminarily on 30 patients, 10 of whom are actually over age 75. And it turns out we were getting a nice about 46% remission rate with CR plus CRI, very low 30-day mortality of 6%. About a third of the patients went on to transplant, even though these are older patients. Basically, what we're hoping is to build a little bit of proof that there might be patients for whom an initial trial of a lower intensity therapy could be followed subsequently by a higher intensity regimen like CPX 351. Again, early days, but more to come. We also at Cornell are continuing an investigator-initiated study to add gemtuzumab ozogamicin to CPX 351. As the audience may know, gemtuzumab did have an event-free survival benefit when added to patients, older patients who were treated with 7+3 induction. So that's a little bit of the work that I've been presenting. In the session that I'm chairing, we're going to hear some interesting things, some of which are already practice changing. For example, there are gilteritinib data being presented. Gilteritinib is a FLT3 inhibitor that is approved for the treatment of relapsed FLT3 mutated AML. Dr. Levis will be presenting data shortly that this agent does have a survival benefit, and actually across some mutational profiles, which he will present, and you're encouraged to review that abstract. So basically trying to distinguish between whether it matters what the allele ratio of the FLT3 was, and it didn't seem to, but also what the mutational profiles of concomitant mutations that go along with FLT3 that may or may not matter. Looks like gilteritinib definitely has a benefit across the subgroups that he evaluated. In my session, there's also some phase 2 data on a non-anticoagulant heparinoid called CX01. Again, phase 2 data combining this drug in older patients in combination with 7 and 3, which look interesting. Trying to think, there are some interesting transplant data, very exciting adoptive immunotherapy of allogeneic T cells for post-transplant patients with adenovirus infection. This looks like an incredible data set and hopefully would be something that patients could actually benefit from in the near future. In addition, using cyclophosphamide for post-transplant GVHD reduction, again, something that might be applicable quite imminently for patients. So these are things that are ready to roll off the shelf. Thank you for your attention.